a respected expert in regenerative therapy with extensive experience and a strong commitment to advancing evidence-based pain management techniques. Dr. Mosmi Datta, recognized for her evidence-based and empathetic management of complex pain conditions, including musculoskeletal pain, headache, and herniated disc together. And also, Dr. Jasnu Topal, sir. I request all our chairpersons to please come on to the dais. Dr. Jasnu Topal, sir. Dr. C.S. Cham, sir.
Thank you.
Ladies and gentlemen, it's my privilege to introduce Dr. Sarita Singh, ma'am, an experienced anesthesiologist and pain specialist known for her expertise in interventional pain techniques and cancer pain. Please welcome Dr. Singh to the dais for her talk on celiac plexus block. Welcome, ma'am.
Thank you. It's a very bad time for post-lunch time, but still we have to do. First of all, I would like to thank the organizing team of ICRA who has given me this opportunity to present this topic before you. Actually, celiac plexus is the basic intervention, and this is focused by the for the budding pain physicians. Yes, celiac plexus neurolysis. Celiac plexus is the largest visceral plexus and is located deep in the retroperitoneum over the anterolateral surface of the aorta. The origin, around the origin of the celiac trunk. It is also called as the solar plexus because it has a very big size. It serves as a relay center for the nociceptive impulses that originate from the upper abdominal viscera from the stomach to the proximal transverse colon. This is the structure or anatomy of the celiac plexus. It lies anterior to the aorta at the level of the T12 and L1 vertebra. It is found near the origin of the celiac trunk just below the diaphragm. Posterior to the stomach and pancreas and superior to the kidney. These are the relative relations, anatomical relations, which is situated retroperitoneally in the upper abdomen. So these are the components of the celiac plexus. It contains celiac ganglion. The afferent fibers, mainly these are the organs which the fibers innervates like pancreas, fibers of the celiac plexus innervates like pancreas, liver and gallbladder, stomach, spleen, kidney, small intestine and adrenal glands. The pain originated from these organs. These are covered by the celiac plexus blocks. The efferent fibers, that is sympathetic fibers, arises from the greater, lesser, and the least splanchnic nerves, mainly originating from the T5 to T12 spinal levels. Synapse is the celiac ganglion before innervating abdominal organs. The parasympathetic fibers are also there. They passes through the celiac plexus without synapsing, continuing to the enteric nervous system of the abdominal organs. So, about talking the celiac neurolysis. The first person who has given the concept of the neurolysis by the chemical agent who was the in the 20th century, and the Lewton, the name of the scientist was Lewton. He published the first paper that we can use the chemical substance to neurolyze to ablate the nerves. Then the main history that began in 1914 when German surgeon Maxi Kapis first described the technique as a form of surgical anesthesia for the abdominal procedure. First publication, celiac plexus block by Kapis in 1914. This was given first for the surgical anesthesia. Initially, it was initiated as surgical anesthesia, but this concept became failed, and finally, this neurolysis of the celiac plexus came for the abdominal pain, for the management of the abdominal pain. So the main indication, chronic pancreatitis, treatment of visceral poor localizing abdominal pain, diagnostic block, pancreatic adenocarcinoma, cholangiocarcinoma, abdominal visceral pain syndrome, upper abdominal malignancies, retroperitoneal malignancies, and hepatobiliary malignancies from the hepatobiliary system. As usual, like other contraindications, there are absolute and relative contraindication when we are going to do any interventions like absolute or coagulopathy, severe local or intra-abdominal infections, bowel obstructions, increased risk of the perforations, where we have to not touch the patient for the celiac plexus block. The relative contraindications are abdominal aortic aneurysm, aortic thrombus, eccentric origin of the celiac axis, large intra-abdominal mass, or patients of the terminal stage like use ascites. These are the main equipments which we are using for the celiac neurolysis, by both techniques, fluoroscopic and ultrasound. There are many approaches for the celiac plexus neurolysis. The retrocrural approach, the anterocrural approach, transaortic approach, and the transvertebral disc approach. So the most commonly approach used is the retrocrural approach. There are many studies who has proven this, that retrocrural approach is the most used approach. But some studies also says that transaortic technique is also very good and very has efficacy. So transaortic, a variation of the anterior approach, needle passes through the aorta to reach the plexus, rarely used mostly, but this technique required the high skill of the pain physicians. The trans-intervertebral disc approach, this is also not very common, but I am usually using this transdiscal approach in my setup. The other one is the very important and the latest, that is ultrasound guided approach. As the new pain physicians who are coming in the field, they are mostly towards the ultrasound techniques. So the ultrasound is more safer as compared to fluoroscopy because it is able to show the vascular structures very clearly. And by the ultrasound, we can use the very precise, very accurate position, location of the celiac plexus. So this is the most useful and very important and very upcoming technique of the celiac plexus block. How to do? The intervention is performed under X-ray guidance. In my setup, I am using mostly the fluoroscopic guided. So the patient is placed in the prone position. Intravenous lines are kept. Their monitors are attached to the patient. You have to be prepared for any drastic problems. So C-arm is placed in AP position and it is tilted C-arm oblique in the chordate position for squaring the T12 and L1 vertebra. Place the C-arm ipsilateral oblique to evaluate transverse process of the spine and keep the needle there. And then insert the marking of the needle is at the anterior border of the L1 or T12 vertebrae. Then give the dye. This is the dye. Pattern. And the important thing is that the margin of the dye do not go beyond the margin of the vertebra. So this is a patient who is having CAGB and is supine in position, and the video is not very good, but I am doing the intradiscal procedure, and this is the two bilateral site. And we have given the dye. Then after that, we have given the 10 ml absolute alcohol with the Zylocard. The main complications in this procedure is the local pain, rectal injury, hematoma, discitis, neuritis, and intraneural injections, cauda equina syndrome, and infections. The post-procedural management is most of the patients, they are having this hypotension. So you should be prepared for the hypotension. First, before taking the patient in the OT, you have to infuse 500 ml or approximately 1 liter of the fluid to the patient. And these patients are also fasted, so you have to be prepared for to manage the hypotension. And in the post-op, there is sometimes I have seen the patients with diarrhea, but this is treatable. So there is a paper which I have published. We have done 30 patients in both group, and I have used the multiple concentrations of the this amount of the alcohol. And I saw that the more amount of the alcohol when I have given, the result was more as compared to less amount of the alcohol. There is another study who shows that transaortic celiac plexus neurolysis with low volume of alcohol is safe procedure. This has published by the Dr. Anurag Agrawal up to 6 months, and this is also very important because in the ultrasound guided we are very accurate and we are very precise, so the amount of the local alcohol is less as compared to other process. There is another study who proves that ultrasound guided and fluoroscopy assisted posterior approach you can also use. There are many publications which proves that ultrasound guided celiac plexus nerve is effective method for reducing pain of upper abdominal cancer. So these are the fluoroscopic and ultrasound guided procedure of the celiac plexus. So those celiac plexus is a very large plexus. So the accurate position of the celiac plexus is not very well known. This can vary according to the patient to patient. This can vary depending upon the disease of the abdominal cavity. This can vary upon the spreading of the tumor, or the local anatomy may be disturbed due to the malignancy in the abdomen. So third one, cryoablation, which these videos and these publications I have seen from the Gautam Das sir. And the cryoablation is also a new technique which came in the light very early, but it has got many publications and many approach towards the cryoablation, because the cryoablation gives the large area of the ablation of the nerves due to the this technique. So celiac plexus is a large plexus, and by the cryoablation we can cover almost all the fibers. So the efficacy of the cryoablation is more as compared to the previous fluoroscopy and ultrasound guided. So advantage of the cryoablation, this approach offers a well-targeted, effective and safe alternative to the chemical neurolysis, especially in complex clinical situations, like when the tumor is increased in the size or the anatomy of the celiac plexus is distorted. Side effect profile is diarrhea in 5% cases, but it is treatable. And there are many publications, that is CT-guided cryoablation of the celiac plexus. This also has a very good result in the abdominal cancer. There are other publications like percutaneous computed tomography guided cryoablation of the celiac plexus as an alternative treatment for an intractable pain cause. This has also showed that it is an effective alternative to NCPB for palliative treatment of celiac plexus involvement. There are many publications. When I was searching the articles to present this topic, there were many publications which I have seen for the cryoablation. So of the upcoming time, this may be placed by the cryoablation of the celiac plexus. I have also seen that cooled RF is also published for the ablation of the this celiac plexus. But in the cooled radiofrequency ablation, the needle of the cooled radiofrequency ablation is too thick, and it can produce the this trauma to the adjacent structures. So these are other publications which favors this cryoablation and ultrasound guided celiac plexus block. The future outcome, what we want? We want significant pain relief, reduced opioid dependence, improved quality of the life of a patient, and repeatable if needed. So this is the advantage of the celiac plexus. In cancer patients, it is palliative, aiming to improve and comfort to the patients. And the possible complications or limitations, temporary side effects which can be treated. So seeing the side effects, we cannot leave the celiac plexus block, and we have to relieve the patient from the pain. Incomplete pain relief may be happen in 20% patient. Procedure related risk may be happen, which as usual, this can be happened with any procedures. So advantage of fluoroscopy and advantage of ultrasound are as I have told. So in the future, outcome of ultrasound-guided celiac plexus block is generally favorable for the well-selected patient, especially those with upper abdominal malignancies or chronic pancreatitis. The procedure can offer safe, effective, and repeatable pain control. Both techniques are effective. Ultrasound, radiation-free. Ultrasound is radiation-free, bedside, real-time, soft tissue guidance, and which is particularly benefited in the cancer pain or ICU settings. Fluoroscopy is also good, but it has its own side effects like radiation. And ultimately, I'm going to say that cryoablation is a new technique which is coming up for the celiac plexus block. Thank you.
Thank you, Sarita ma'am.
Thank you, ma'am, for the wonderful presentation. Q&A session will be after the all speakers have ended.
One special announcement. 40th ISSP Con will be held at Hyderabad. We are excited to tell you that there is a counter outside Hall B where you can register with a discount. So please do register in it.